teaching hospitals, patients that came through consecutively from primary care for any indication. And as I say, it's completely turned off to clinical care, except for the fact that if there was something that triggered, if there was a difference between the AI algorithm and the clinical report, they were reviewed to ensure we hadn't missed any cancers. And that created a lot of work. So in total, we did, so about 6 months, we did just over 5,500 patients, some of which had repeats, because that's the nature of the GP pathway. And each one was looked at by the algorithm and compared against 3 different algorithms, although in the end we just went for 2, which was radiologist report and the NDT diagnosis of lung cancer in the region. And then the third part is a 6-month CT scan, and I'll explain perhaps in a bit why we didn't bother going into that in too much detail yet. So they're looking through diagnostic accuracy and then assessment of failures. So as I say, just over 5,500 chest X-rays and 5,500 patients. And chest radiologists, who predominantly did almost all of the chest X-ray reports in this cohort, identified 158 potential cancers. The algorithm we tested identified just over 1,000. And within that cohort, there were 92 cases that were diagnosed with lung cancer. So this is a big, messy slide, but essentially the sensitivity of the algorithm is pretty comparable to a radiologist reporting in the sort of low to mid 60s, which is not far off what a radiologist. I was a bit nervous when I saw this, but 60-odd percent, 65% is not too bad for a busy functioning department. What is interesting to me is specificity and positive predictive value. So there's quite a big difference. Although from specificity, it doesn't look like there's a massive difference between a radiologist and the algorithm. But when you convert that into a population-based metric with positive predictive value, it significantly drops how useful this was in a clinical setting, with only 5% of patients flagged as positive actually then going on to have lung cancer. One of the measures that we can look at is false positives per image. It's a bit of an unusual thing to get your head around, but essentially it's the number of false positives. No, the number of false positives divided by the number of images taken, and it's a way of sort of measuring background false positives. You can see that there's significantly lower false positives when a radiologist is looking at the chest X-ray. So here's some examples of it. So no prizes for spotting this lung cancer. Probably not going to make a massive impact on the patient's journey here, because most people are going to spot this whilst the patient's in. Something like that, though, I can see will massively improve. There's a reasonable chance that the radiographer that's taken this plain film may not have spotted that abnormality, and the patient may have gone home, and we may have to bring them back in 20 days. And then this, I think, is an incredibly good spot. So it's hard because there's a circle drawn around it, but I'm not sure whether I would have spotted that as a cancer. But going back through, that was definitely the cancer. So looking at failures, now there were quite a lot of failures, and the vast majority of them were false positives. The false negatives I've not bothered putting up here actually, because it basically performs similar level to a radiologist reporting. It didn't miss many significant cancers that were felt to be identifiable on the chest X-ray. What I was concerned about is the number of things that it picked up that were not cancer and flagged as possible cancers. And so looking through those and trying to associate what the finding was that it was identifying and putting a marker around. I assumed before doing this it was going to be non-cancerous pathology, so consolidation or something that is not normal but is not cancer. But actually normal anatomy was by far the most common thing that it was flagging, particularly the ribs. Osteoarthrosis of the first rib where it meets the sternum, but also hilar, and it's hilar that I think is going to be a real problem. So here's some examples. So most anyone that reports chest X-rays will feel pretty comfortable ignoring osteoarthrosis of the first rib. It's symmetrical, it's in the right place. We get shown this all the time and pretty comfortable ignoring it. I would argue that that is a lot more difficult to disregard. If someone shows you a hilar that's not been documented, that they think it's abnormal, then maybe you could delete the registrar's report that says, I think your hilar's abnormal, and nobody ever questions it. But actually, if someone's drawn a circle around it, I think you're going to have to be really confident to not do a CT scan there. And then this is another thing that I think is, this is a bit of an unfortunate case, but essentially it's drawn a circle around the pacemaker, but what it's not done is drawn a circle around the left hilar tumour, and I think there's a real concern for me with distraction. The more information you are shown, that comes up and you go, what a silly algorithm, it's drawn around the pacemaker. Normal, and then we miss the things that we potentially otherwise don't miss. So I think what I'm trying to say is I don't think it's without risk. Okay, so as a result, we've decided not to take this further with this algorithm, but we now have a nice data set of patients which have been well phenotyped for their diagnosis. So we've got their radiological report, we've got their CT scan, and we've got their final diagnosis in an MDT. So we have a really nice cohort of patients to start looking at other algorithms. So then went to a platform company, Blackford in this instance, to say, could we use your platform to try and streamline the process? Because I'm a bit weary that all that's going to happen is we're going to start at the top of the list and drop down the list, seeing how effective each of the algorithms is. So could we come up with a way of comparing different algorithms all at the same time in the same data set, and then use that to try and decide what to do next? And that's taken a year and a half, and this is where we're at. So this week, hopefully, we will be sending the data, having had approval, and I can tell you the process through which we've had to go to get there. The whole point of this, from my point of view, well, number one is there's a massive lack of data available. That's what NICE said, and that is what I think is the biggest the biggest sort of limitation to implementing AI in the clinical setting, that no one really knows in clinical. When you deploy, how is it going to, what's it going to do, and what are the risks? So the plan is that this is going to form part of our procurement process to decide which of the different vendors we are going to then go with to go forward. So what have I learned? Quite a lot, actually, and not there's loads of it that is positive, and there's loads of it that's not quite so positive, I'm afraid. So local validation is a massive amount of work. We were looking at 6 months worth of cases. I think you have to do big data sets because only 1% of the population actually has the condition I'm looking at. So in order to be able to look at it, you have to do huge numbers. And you could argue that 100 cases of lung cancer probably isn't actually anywhere near enough. There's a real issue about what you use as your gold standard. So this is real clinical practice. You can't biopsy everybody, you can't CT everybody. So the patients that have been called no cancer, well, they disappear off into the ether. You assume if you follow them up over a period of time that they will hopefully come back and represent at some point, but there's the potential that there's some loss there. But if you use CT scan, you massively skew your population towards symptomatic patients with abnormal chest X-rays. So, and if you use just the radiological report on its own, we all know it's not correct. So each of those gold standards has its own inherent problems as to why it might not be the best to use. Do I have anything else to say on that? Yeah, you have to repeat it. I mean, if you deploy, you need to make sure it continues to work. If it ever changes, you have to go back and do it. And that's probably okay for the most, because you will test it at some point in order to deploy, so you have a nice data set ready to go. So for small changes, you could probably be getting away with smaller amounts of work. But if it's anything bigger, like a new finding that's stuck in there or something, then you've got the whole thing to start all over again. And the whole point of this, to me, is to try and streamline our processes, improve workflow, and actually this, to me, is a significant amount of work. I had issues with information governance for ages. Some of the questions that came up that I still don't, I'm not going to claim to have the answer to any of these, is it research or is it service development? And the pivotal question seemed to be, do you think this is generalizable to a population? That's what seemed to trigger it into the world of research. And I think if you do this in a way that, if you try and get rid of all biases as much as possible, like granted in real life data sets, there's going to be loads of biases, but if you try and do it in a non-biased way as possible, then hopefully it is generalizable. I'd like to think that what happens in Leeds would be applicable, would work for us. How it works when you start going further afield to places with less deprivation, I don't know, but that seems to trigger a big problem. And the reason it triggers a problem is because you've got two separate departments, each of whom washes their hands of it. So R&D say, nah, service development, mate. You need to speak to those guys. This sounds very much like research. So you end up getting caught in this sort of middle ground where no one's really taking it on and driving it forward. Is this legal use of patient data? Comes up a lot, and obviously it's a very important problem. It's what people are really concerned about in healthcare and AI. And I'm definitely not going to claim to be the right person to answer this, but I will show what we've managed to cobble together. cobbled? No, what we've got together that works quite well. And then what really seemed to cause a problem was when we started thinking about sending data off-site. So doing stuff behind a firewall felt reasonably safe to IG. As soon as we said, I want to send this to a platform outside the trust, suddenly everything became much harder. So one of the things we did to try and improve things is to bring up the Sheffield 3D Lab database retrospective database ethics. So essentially, this is our proposal for how we can use data in a way that is safe, follows GDPR, is fair to patients. So we follow the NHS. It has rules for how to anonymise data or pseudo-anonymise data. We have panel oversight over what's going on. We have lay review of any proposals and any outputs to make sure that patients are being considered. And we have monthly meetings on progress. Okay, more focusing in on the algorithm themselves. So I didn't realise how important this was, and it seems a bit obvious now, but how the algorithm was trained is important. So this one that we were looking at was trained on plum normal or biopsy-proven lung cancer. And as we all know, that is not what the reporting pile of chest X-rays looks like. There is a vast amount of stuff in the middle. And so this has never seen a pacemaker, it's never seen calcified blood, it's never seen calcified granulomas. So it's no surprise that it gets those wrong. So if you haven't ever seen a calcified granuloma, that probably looks like a lung cancer. If you have never seen a pacemaker, that's round and dense. It's sort of, it fits. And I'm not sure where the first rib comes in, but I assume that's because they were scattered or training on young people maybe to try and make sure they were definitely normal chest X-rays, but I've not quite worked that out. Fine. Thank you. Okay, the next thing is the importance of the test population. So this case, when we looked at the test data set that was published in the non-clinical data set by the company, they had a false positive bruise rate that was identical to what we had. So 18 out of 100 patients with chest X-rays were falsely attributed to lung cancer. So it was exactly the same. But in their population, they have 50% of the patients having lung cancer. And so you can see why, when you then say that's the one case that has lung cancer, it makes such a huge difference. The number of positive cases massively outweighs your false positives when you have a really, really high prevalence. And when you have a small prevalence, all you get is the false positives, and you struggle to find the abnormality you're looking for. Just as a little fun bit, that's what radiologists look like. So I feel quite comfortable that we're doing an okay job. This is the next thing that I always hear, which is, but it has a good negative predictive value. So why don't you just look for the normals, and then you look at the other ones, and call the ones that have been called normal, and those ones, you look at those ones. But then if you look at the population, that's the one that's abnormal. So to get a negative predictive value of 99.2%, you only need to improve your you need 1% improvement to get there. The way that it's biased is really difficult to test, and these population metrics are really, really difficult to assess in sort of local states. I mean, this is a bombshell for me. I really don't know what the answer to this is, so I've left it blank. Because we're trying to assess performance across multiple different algorithms. I don't even know what I think is okay. I mean, the performance of a radiologist, I suppose, is what we've got, and it works, but it's not really the comparator it should be, because the comparator really probably should be the person that's done the chest X-ray and is ringing the radiologist saying, should we do a CT scan? But I have no way of capturing that information. And it's going to massively vary depending on what setting you're using it in. If you're screening for cancers, it's totally different to if you're looking for non-accidental injury. You might want to overcall it a bit so that you investigate. It's a really difficult question. The importance of terminology. I feel like an old-fashioned radiologist thinking about this now. But the Flashing Society for like, what, 40 years, 50 years? Ages has defined chest terminology. So everybody uses the same words, and I know what a nodule means to you, and you know what it means to me, and we're all on the same page. And this is just an example from a company, and it doesn't matter who it is, but that is not a nodule that has been labelled in the middle there. That is a mass, because it's over 3 centimetres. And that makes it really difficult to assess performance. So if you label for nodules, that is, to me, incorrect. But does it, if you label for masses, then it is correct. And how do you compare the one that does masses to the one that does nodules, because we're all measuring different things. And that brings me on to the most ridiculous slide I have. So this is the output of findings of 6 different algorithms that we're going to look at. So the one on the left has just 5 different labels that it come up with, and the one on the right has so many I didn't want to count it. And we're trying to work out which of these labels is interesting, and should I test, and what does it mean? How do I compare? I don't know where to start really. So I started with looking through and deciding, as a radiologist, which of these do I think is the most likely to be lung cancer, which seemed reasonable. So I started going through. Lots of them say nodule. Very few say mass. I mean, to me, you should have nodule and mass, based on what we've already discussed. But do you include consolidation? Because occasionally we have the old-fashioned bronchoalveolar that is a consolidated pattern. Do you include effusions? Do you include abnormalities? Interstitial markings, because you're interested in lymphangitis. There's so many different routes you can take with this. And then when you go really deep digging in, you find words that you don't know what they mean. So opacity, which interestingly is defined, which surprised me, because I keep telling people off using opacity because it's non-specific, it doesn't have a definition. It actually does have a definition, which is a non-specific one. That surprised me. But then there's one that has clawed imaging, who knows what that is, and infiltrates versus alveolar pattern appears as a finding for the same vendor. And I mean, I don't know what either of them mean, but they both sound like they probably mean the same thing. Terminology. Regulation. I know nothing about regulation. I'm not going to pretend to know anything. However, what I do know is it doesn't mean it works. It means that you can buy it, you can use it, but it does not mean that it's been shown to be effective. They are important because you need it in order to use it, but it doesn't mean that anyone has done the background check to make sure that what you're using is going to be effective. And that, it boils back to what I said at the start, which is there's a massive lack of validation data for any minority group performance. I mean, someone's got to plug for the little guy, and there's no way we could ever test it. We only have, this took ages and ages to work through, and we have 100 cancers, and the black population that we looked at was 3%. So I'm not even convinced there will have been a cancer in that group. I didn't go specific through looking, but how do you start working through trying to find out which groups of patients it doesn't work in? It would have to be massive numbers of patients. So I'm sorry to be a bit negative, and I know everyone else has been very positive, and I think it's all, I genuinely do think this is going to make a benefit. And if it's done right, we can definitely improve pathways. But there's an awful lot of work in order to get there, primarily through collection of data and identifying where it works and where it doesn't work. And I don't think local validation should be ignored. It's very important how it works in your population. My biggest concern to leave on is my concern about over-investigation. A chest X-ray takes, what, 30 seconds, a minute to report? A CT scan takes significantly longer, and we find all sorts of incidental findings that no one knows what to do with. So to me, the risk isn't to the patient, where I think we're probably not going to miss many cases, although well, there is a risk to the patient, which is over-investigation and all the harm that causes. But there's a real risk to the radiology department that we drown in CT scans if we were to implement. So yeah, sorry to be a bit of a downer. Thanks to everyone that's been involved. It's a massive amount of work, and thanks for the attention. I'd be very happy to take any questions.